Hello and welcome everyone to the first Nightingale webinar of 2022. My name is Irati Rodriguez and I'm a young cancer nurse representative from Spain. I'm currently working in the United States at the American Cancer Treatment Centers of America and getting my nurse practitioner's degree over here as well. So I'm going to be one of your chairs for this webinar. And I have the pleasure today to be joined by Constantina. Constantina, would you introduce yourself?
Yes, hello everyone. Thank you again for your attention and to be here. My name is Constantina Glogoni. I'm Young Cancer Nurse Representative for Cyprus. I'm a member of Communication Working Group and I'm working as a research nurse at German Oncology Center in Cyprus. I'm really happy to have you all here. So enjoy the presentations. You know the topic is the pain, and maybe Radi, you can.
Yes, so well, today we are going to be talking about pain as a response to the request of our young cancer nurses. So we are going to be discussing pain in the oncology patient. Pain, as we know, is a common complaint among cancer patients. Pain can be acute, can be chronic, it can be as a result of the disease process. It can also be a side effect of different therapies, such as chemo, radiation, surgery, and it can also be related to psychological distress, and it can even persist even after remission has occurred. So we know that pain highly affects the well-being of oncology patients and can negatively influence their health outcomes and quality of life. Oncology nurses are key in the management of pain, and through their assessment and interventions can improve outcomes and advocate for the best pain management therapies available for each patient. So without further ado, I'm going to let Constantina introduce here our first speaker, whom we are very grateful to have today.
So firstly, thank you for being here, Dr. Pavel Pasas. He's a medical oncologist from Czech Republic. He's working at the Department of Oncology at Model University Hospital. He's going to start with the topic about cancer pain in general and its management in inpatient settings. So the stage is yours, Dr. Pavel.
Okay, hi everybody. It's my great pleasure to be here today to give you a short talk about cancer pain and its management. So once again, my name is Pavel Pasas. I work as a physician at the Department of Oncology in Model University Hospital in Prague, Czech Republic. Basically, I take care of patients both in the inpatient and outpatient setting. Focus of my presentation is more a bit to the inpatient management, but it's mixed. Next slide, please. Here's a brief overview of my talk. So I'm going to give a brief introduction consisting of mechanism of pain, how it's being produced physiologically, the prevalence of pain in cancer patients, and then I'll proceed to some principles of pain management and pain treatment, and I'll wrap up my short presentation with a case report. Next slide, please. So what is actually pain? So pain, we can say that pain is an unpleasant sensory and emotional experience that is associated with potential or actual tissue damage, but the pain is always subjective. It's personal experience, and it's influenced by biological, psychological, social factors. But it's a unique experience of a patient, of a person, and in this point of view, it should be taken. Of course, pain has its adaptive role, evolutionary, but when it's not controlled, it may have maladaptive role, it may have adverse effects on function of a person, of a patient, and of course, it may decrease patients' well-being. We use, of course, verbal description of severity of pain, but then, of course, some patients are unable to give us a verbal description. That's why we use, of course, also non-verbal descriptions, and I'll talk about it a bit later. Next slide, please. Okay, how does it come to pain? So at first, we have some stimulus. We have some stimulus in the tissue. That may be a burn, that may be a pressure, that may be loss of tissue integrity that is being percepted of neurons that are basically in the spinal cord and send their axons to the skin, the peripheral axons, and their central axons, they send them to the brain. So the perception and transmission is neuronally mediated, and those neurons from spinal cord, or to be precise, from dorsal ganglion, they send their projections into brain thalamus and then to sensory cortex. It's in the cortex of the brain where the pain is actually experienced. So that's the place, basically. So that's why we talk about nociception and pain. So nociception, that's the happening or mechanism of stimulus detection and transmission, but then pain, it's the subjective experience, as I've said already. Next slide, please. What are the prevalence of pain in cancer patients? We can say pain is fairly common. In the patients in the advanced stage of the disease, the prevalence is almost 3/4 of all patients. Of course, it's contributing to poor physical and emotional well-being of the patients. Some reviews, they indicate the pain range, so it's ranging from 1/3 of the patients after curative treatment or in the initial treatment to almost 2/3 patients with advanced or metastatic or even terminal disease. So we can say pain is highly prevalent, and of course some kind of cancer have let's say more or higher prevalence of pain on average, such as pancreatic cancer or head and neck cancer. Almost half of all patients experience pain. Next slide, please. How do we assess pain? So assessment is something that needs to be done and needs to be redone. I've talked about, of course, some verbal description. Then I guess all of you are familiar with visual analog scale or verbal rating scale or numerical rating scale, respectively. From my point of view as a physician, most of the time I use verbal rating scale or numerical rating scale. Almost I do not actually use a visual analog scale at all. That's because when the patient is unable to tell his or her pain experience, then we just perceive its severity out of reaction to perceived stimuli, such as manipulation with the patient and so forth. The point is to assess the pain at first and then reassess it regularly, and we can talk about it a bit later. Next slide, please. So principally, how do we manage the pain? The patient should be really in the center of our focus, not the pain as particular. So the patient should be encouraged to take a role to participate in treatment and pain management. We use the mainstay of treatment of pain management is pharmacological treatment. we should aim to reduce the pain as much as possible, and then to prevent the rebounds of the pain. So that's why we use so-called around-the-clock administration of drugs. Of course, we need to take into consideration various kinds of drugs, analgetics. I'll talk about it later. We should so we should give those drugs on a regular basis. We should prescribe them on a regular basis, not so-called on-demand schedule. Of course, when the patient is able to, we should give those drugs orally at first, but when it's not sufficient or it's impossible to give it orally, then of course we have another routes of administration. Okay, we can talk about so-called baseline pain that is constant, and then so-called breakthrough cancer pain. Sorry, I'm missing the word pain there. So that's a transitory flare of pain that occurs in the background, and these episodes are brief or rapid in onset, can be short in duration, but can be also longer than those 30 minutes that are in median. When managing the pain, we use so-called stepwise approach, step-up approach. So we combine the analgesic drugs according to the potency. It's being described as so-called WHO analgesic ladder. Next slide, please. So how do we manage mild pain? So the mainstay are all well-known drugs such as paracetamol or acetaminophen in the US, NSAIDs and metamizole. Paracetamol, unless the patient has some substantial liver injury, we use this drug fairly often. It works as a weak inhibitor of synthesis of prostaglandins. Those are molecules that signal the presence of inflammation, danger, or damage to the nerves in the skin. And they serve as a substrate of nociception and then pain experience. Basically, paracetamol or acetaminophen, we can really say it is the mainstay in treatment of mild and moderate pain. Those are the first two steps on WHO analgesic ladder. We can give it orally and intravenously. There's some maximum dosage that should be really fit to particular patient. Then we have non-steroidal anti-inflammatory drugs such as ibuprofen and or diclofenac. There are plenty of them. Basically, their mechanism of action is similar, that they block the synthesis of prostaglandins, those molecules, those inflammatory molecules. I got here some review that they really work. Unfortunately, we should not use them long term, and then patients with peptic ulcer disease and chronic kidney disease, because they alter blood perfusion of the kidneys, and also they heighten the risk of exacerbation of peptic ulcer disease, even when it's medically managed. Then we have this drug metamizole that's been here for 100 years, and it's not so restricted in patients with chronic kidney disease, which is good. It has also very good spasmolytic properties, so we use it here fairly often, and it's a really useful drug. As a caveat, it can cause or worsen hypotension. That means when the patient is not hemodynamically stable, we do not administer this drug. And of course, we can administer it orally and or intravenously. Very good way of administration is liquid drops. Next slide, please. What about moderate pain? I've got here two drugs, tramadol and codeine. Both are basically weak opioids. Tramadol is weak centrally acting opioid. Its efficacy is 1/10 to 1/16 of morphine. It is good to cover mild to rather moderate pain. It comes handy with, in combination with paracetamol or acetaminophen. Caution, it can cause and fairly often also causes dizziness, nausea, vomiting in patients. That's we always have to ask if the patient has had taken tramadol and if there were any side effects. Codeine, we do not use this drug so often. It's a precursor, so it's metabolized to morphine. Some people do this slowly, some of them fast. So the result of analgesia is really unpredictable. We use it rather as an antitussive, so to dampen the cough of the patient when there is any. Next slide, please. Okay, how about severe pain? Strong opioids, those are the drugs of choice. We know several of them: morphine, fentanyl, oxycodone, hydromorphone are several of them. They act as opioid receptor agonist in spinal cord and brain. So the first choice of drug is really morphine. We of course can give it orally, we can give it subcutaneously, we can give it intravenously. It is the drug of comparison because the most potent. So other opioid drugs are then compared to morphine according to potency and dosage, which is in the table there, down there, the slide. Fentanyl, another fairly common drug. It's really rapidly acting opioid. So its effects, they come, let's say, in tens of seconds, morphine rather minutes. Fentanyl is available as sublingual tablets. That's a really, really good way of controlling breakthrough cancer pain. And then, of course, it's available as transdermal patches. That's a way how to control baseline pain. So those two formulations are the most common. Oxycodone, it's a orally available drug, and we give it fairly often to patients with bone metastasis. And our experience is it's the control of bone metastasis pain is more easily achieved than with morphine. Next slide, please. Okay, so there is a diagram. How do we really, or how can we proceed controlling the pain? So we start with paracetamol or any NSAID. Of course, we assess the pain, and so if it's still there, we can use weak opioid such as tramadol with paracetamol, for example. If it's still not enough, we can then give or should give a strong opioid drug, and then it's a way of or a matter of titrating the dosage and controlling potential side effects. They are pretty common when considering the opioid drugs. Patients can have constipation, so we need to assess it regularly as well and treat it accordingly. Next slide, please. So I proceed to short case report. So we've had a 63-year-old male that has been treated for metastatic prostate cancer. Unfortunately, he was diagnosed with metastatic bone lesions, and primary tumor side was a prostate. So been treated for 2 years, hormone therapy. Then he progressed, had been given chemotherapy, plus of course corticosteroids and bisphosphonates to control bone integrity. Unfortunately, the disease was progressive, after the treatment, and the patients eventually wasn't suitable for ongoing oncological systemic treatment, and so it was indicated for palliative care. I stayed at home. The pain was controlled with paracetamol plus tramadol combination that patient was taking orally, and as it was not sufficient, he'd been given fentanyl transdermal patches, and we really had to gradually increase the dose of fentanyl patches. Then it was the doses were really high, 300 milligrams of fentanyl per hour, and the pain was still intractable. That's why we decided to admit the patient, to our department to titrate analgesia to adjust the therapy. So we stopped really the fentanyl patches as they were not enough. The patients started morphine subcutaneously to get the pain under control as fast as possible to really relieve the patients from the pain. So we've been giving 10 milligrams of morphine 4 times per day subcutaneously, and we started oxycodone as opioid analgetics that we have good experience with controlling metastatic pain. So we started some basal dose, and slowly we're getting up to 160 milligrams twice daily, in the morning and in the evening. And that was actually sufficient to compensate the patient's pain. He was able to stop the morphine subcutaneous injections, and he was actually able to be discharged home with some home palliative care. We've given him sublingual fentanyl tablets as a rescue analgetic for breakthrough cancer pain, and of course the oxycodone wasn't really the alone analgetic drug. It was given in the combination with paracetamol, and right now the patient is almost 2 months after the discharge, and the doses are sufficient till today. Next slide, please. So to wrap it up, we can say that the pain is subjective experience. We really should take into account the patient as a person to discuss with him or her properties of pain and the response of treatment. So we need to really do assess and reassessments. Generally speaking, we use a stepwise approach for controlling the pain. That's why we use combination of drugs. And last, we can say eventually pain can be controlled. It can be get under control. It's only a matter of doses and correct medications. So that's actually all my talk. I thank you very much for your kind attention, and I'll be glad to answer any questions. Thank you.
Thank you very much, Dr. Pacas, for your contributions today.
I'm sure that palliative care, it must be from the beginning. So I hope in the future you will have the opportunity to include the patients from the early stage of the cancer, because it's really important to educate them from from the diagnosis to be prepared what they have to wait from the side effects and how they can manage them. For sure, it's a disadvantage to have the care only Monday to Friday, but I hope that you will have the chance to have a 24-hour service in this in the palliative care. So we have a lot of questions, but let's begin with Dr. Pavel. Let me ask you two questions. The first one is if you use the infusion pumps at home, at the hospital, and if you introduce them for the outpatients too. And what about the CBD oil? I mean, something new for few patients, but if you, let's say, are positive about the cannabis oil for the pain and so on. So you can tell us?
Yes, we do use syringe drivers or pumps regularly in the inpatient setting when the pain is intractable with, for example, regular doses of opioids given subcutaneously. Our department, we do the outpatient care that we provide to our patients is in a clinic setting. I mean, the patients come to us. We cooperate with mobile palliative teams that are based in Prague. And yes, I know they use syringe pumps at patients' homes. Basically, it's the setting of pre-terminal or terminal disease when most of these indications of continuous IV infusions of opioids is. I'm sorry, I did not really understand the second question.
About the cannabis oil. The question is, yes, if you use it.
Okay, yes. So cannabinoids, the legal situation in the Czech Republic is changing rapidly. So it's been legalized only several years ago. So the limit of our experience with cannabinoids is limited. So we at the Department of Oncology do not use them. The patients, from time to time, the patients consult us about the use. So we basically cooperate with colleagues from the clinic of pain. So we do have pain clinic in the hospital, and they manage the patients with cannabinoids. From our limited experience, they'd rather act as a let's say appetizer, or rather you get my message. They increase the appetite of patients. Most of the time they suffer from cachexia and this complication of treatment disease, rather than sole painkillers. So they've been given in combination, from what I know here.
Okay, and in combination with these two questions, I will ask you one more question. Do you have any other scales or biomarkers to, let's say, assess the patient if they cannot tell you about the pain? I mean, if they cannot talk, or maybe, do you have any blood sample specialist or something?
Then the assessment is, of course, much more difficult. Our hospital has some scales for this particular situation when the patient is unable to tell us, but they mostly been used in the ICU setting. They are too time-consuming. Unfortunately, we do not really have a person for the particular task, so we just use our experience and when the patient is been taken care of, for example, hygiene, the kind of stuff, and we do see painful reaction for our stimuli. So that's when
the
we
vital signs and so on. So there's not some
it's just a matter of
specific
physical examination and clinical judgment. Yeah, that's how I need to really say that way.
Okay, thank you.
I've noticed a question about a team who consists actually our team of healthcare professionals. Maybe I can answer this question. Of course, always it's a team of physicians and nurses, and let's be honest, you are in the first row, you're in the first front because you're with them. Time considering you're in the most close contact and closest contact with the patient, so our nurses really do give us vital information about patient status and pain status. Another question was about handling morphine pumps or syringe drivers. Again, nurses do that inpatient and both outpatient setting wise. So it's a teamwork, it's a team play. That's it.
May I add something? Both, if you want to answer. What do you think about the complementary therapies, like if you include them? Because we talked a lot about the medicines and how to assess the patients, but what about the other things that they can do? Do you recommend to your patients, for example, the acupuncture or the art therapy, music therapy, aromatherapy, or something like this? Do you recommend them?
Okay, we do discuss complementary treatment with them. Some of our patients are motivated to pursue the kind of treatment, and we do not, of course, do not discourage. I always ask my patients what kind of complementary or alternative treatment are they seeking. Some of them it's acupuncture, some of them want to try some herbal substances. That's the time I really need to know what kind of herbal substances they'd like to use, because some of them can have some drug interaction effects, or even they can possess a risk for kidney or liver function. That's what I do. Of course, we do provide spiritual care, psychological care as well. Our experience is actually really minority of our patients would like to have this care included, speaking inpatient. Don't know really why. Czech Republic is a really atheistic state. That may be the reason. My personal guess, the majority of patients, they have really courage, or they courage because they're courageous, because most of the time they just go on, they put up a fight with the disease, and yeah, we're here for them. And any other perceived psychological care is unnecessary according to them. Maybe that'll change.
Sorry. And what about you, Pavel?
Okay, I can again speak of the hospital setting, inpatient, outpatient in my clinic. I always am very grateful when I have a chance to speak with patients' relatives, because it's another source of information. It's another stream of information. I can have really skewed or biased view of patient's actual status when I've been given information only for him or her, from him or her. So his or her relatives Again, another vital source of information, including pain management. So yeah, my daddy, mommy is really in pain, even when he or she is really so courageous that they won't tell you. So, that's just another piece of information. So really, I'm really glad when I can speak with them.
Okay, so it's important to include them in the treatment because they usually push the patient to avoid the medicines or to take more herbs and so on. What I took from this webinar is also the importance to start with palliative care from the beginning and to educate our healthcare providers how to manage the pain because as you already know, we have opiophobia is very often in healthcare providers, and this is bias for our patients' pain. So we have to educate the nurses, the doctors, how they can prescribe, for example, as Dr. Pavel told us, the medicines, and how can we collaborate with the teams like Andrea's team to start from the beginning of the diagnosis and be prepared for the end. Can you tell us a take-home message, one from Andrea and one from Pavel, something that you want to take home after your presentation?
Yeah, I really need to say almost the same. We treat the patient as a human being. She really should stand in the center of our attention and of our general management. I would like to say pain is always manageable. It's a matter of resources, experience, etc. How do we manage it properly? But it's manageable.
Thank you so much. I'm sure a lot of nurses, patients, families are very happy to hear, that pain is manageable, because sometimes I think that it doesn't feel that way, especially for patients when they are suffering. So I think that we are running out of time. So if no one else has any further questions, I once again want to thank you both for agreeing to be with us today. And I also want to say thank you to everyone who has joined us today, because I know that we are all very busy, so it sometimes can be challenging. So thank you everyone. And here's the information about the next webinars. So the next one is going to be on the 24th of October, same time, and it's gonna be actually about adolescents and young adults with cancer. So we encourage all of you to join us again and learn about this very, very interesting topic.